Jeroen, why don't you first introduce the case, because we're here in the room with the endoscopy.
And just before introducing the case, there's somebody next to you that we haven't introduced yet. We've got another fellow, an IBD fellow, Thibaut Taalman, who's with us for the past months. So he started the endoscopy already. He's helping us out today as well. He's starting in Kortrijk. And so this is perfect for him to learn both on endoscopy and IBD. Maybe you can ask him later on what his goals for today are as well. But just to present
what are your goals of the day?
So yeah, I'm interested to see how the expert endoscopist looks at different lesions and how some techniques might differ between the IBD specialist and the expert endoscopist.
Perfect. So just, why don't you go ahead and introduce the case then, Jeroen, while we go?
Yep. So this is an 80-year-old man who had a history of rheumatoid arthritis, being treated with sulfasalazine and mainly NSAIDs. In the past, he received some other treatments as well, but they basically did not tolerate them. And so that's why he was treated with NSAIDs for a long duration of time, with a high dose even. He took 3 NSAIDs on a daily basis for a long period of time. He has a history of a perforated diverticulitis, for which he underwent a sigmoidectomy. So that's why you'll see an anastomosis at around 20-30 centimeters, which is slightly narrower, but easy to pass since we're already in the ileum here. And so basically we saw him for the first time in 2022. He presented after a hemorrhoidectomy with a wound in the perineum that healed poorly. He developed a bit of sepsis and he had diarrhea. And so that was the first time we were starting to think about Crohn's disease. So we scoped him. And if you go to the next slide, PJ, you'll see the first lesions that we found here on the slides. Just one more click. Yeah, so you can see that immediately we found severe ulcers, which looked a bit, let's say, annoying or a bit, we did not feel very comfortable seeing those lesions, and it were really different skip lesions throughout the colon with normal colon in between those lesions. So we took biopsies, no signs of dysplasia. Then there was obviously doubt, is this a Crohn's disease patient or not? And in the end, we decided to proceed with the treatment for Crohn's disease. So he was started on beclomethasone and Ustekinumab because of his age, and an indolent prostate carcinoma, which is being followed up. So we chose that biologic compound because of the history. And so we started treatment, and in the initial biopsies, there were actually no signs of chronic inflammation. So that was a bit weird. But at the same time, we started to, in accordance with the rheumatologist, of course, we started to taper the NSAIDs. And so along the several endoscopies that he had, you'll see some more